Okay,
Okay,
over to you, Gabriel.
Over to you.
Hello, can you guys hear me?
Yeah, thanks, Justin.
Okay,
Good,
let me just do.
good afternoon to everybody.
Sorry, Gabriel. Let me do the intro.
Then we'll get you to introduce yourself.
Yeah. So, greetings, everybody. Welcome, Emmanuel, Nyon, Philip, and everybody else who will join later. Greetings. Today is the discussion on the health sector. We're delighted to have Dr. Gabriel Loi giving us his experience and input on what the challenges are in the health sector. As we all know, Sudan struggles in many areas. Historically, as a war-torn territory, a lot of the health responsibilities fell on international NGOs and various other people, churches that were helping us. We've been independent now for a number of years, but as a general rule of thumb or the culture, very little is spent on health in many of the developing world. South Sudan may face the same scenario, but clearly we're a very small population, and if a substantial figure could be allocated to health, it can cover everybody. The Charter, as an emerging think tank, a concerned group for the welfare of our state, hopes to see a social contract that it also embodies the healthcare sector and provisions, particularly for the elderly, the vulnerable, the disabled, and war heroes as well. And health, as we know it, it's a prime human right, as has been stipulated by the UN and others. So we want to hear from Gabriel, an expert in the field, a medical doctor, somebody who's very experienced and has worked for many years in the Ministry of Health and in the health sector in general, to tell us exactly what are the challenges, what is the state of our health, and what does the future hold, and what can be done better in order to ensure the welfare of our people are protected. We, as a rich territory, yes, we may have institutional issues here and issues of historical differences and wars, but it doesn't negate the responsibility to ensure the well-being of our people through, hopefully, a social contract at some stage. So we're very delighted to have all of you here, and we pass over to Dr. Gabriel. Thank you.
Yeah, thank you, Justin. Am I clear?
We can hear you, Dr. Gabriel. Go ahead.
All right. So, greeting everybody. You have already introduced me, Justin. I'm Gabriel Loi. I work for the Ministry of Health. I've been in the ministry for some time. I've also, before joining the ministry or before CPA, I have also been working in South Sudan here with a number of international NGOs. I work for Care International. I work for MSF Switzerland. I work for Christian Mission Aid, all in South Sudan here, before the CPA and before the peace, and before we became an independent country. Apart from health, I have also been interested in other issues beyond health, other national issues of concern. So I've been a columnist with a number of papers. I have been doing some media work, some radio talk show, TV talk show, and yeah. So currently, I am the Director General for training and professional development at the Ministry of Health, but I have also been holding other positions in the same ministry. So I'm glad to be here, and I will try to mention key elements of the topic under the discussion, which is basically the health sector, or the health as a social contract, focusing on the health sector in the Republic of South Sudan. Is a vast topic, is a big one, but I'll try to summarize and within the time frame of this program to highlight key issues of the health sector in South Sudan. To start with, generally, any health system is based on 6 key pillars. You can call them pillars, you can call them building blocks. I will touch on those key 6 pillars or building block of the health system in relations to South Sudan, in terms of what is happening and what need to happen moving forward. So to start with, one of the main building block or pillars of the health system is health service delivery. When you talk of health service delivery, you are talking about the package of service to be delivered, the organization of delivering those package of service to the people, to the intended populations. In the context of South Sudan, when we talk about the health service delivery, we are talking about 44% of the total population who access those services. So in terms of accessibility, the official figure that we have in the health sector is that only 44% of the population of the Republic of South Sudan access those essential services across the country. That was, by the way, before the crisis of 2013 and 2016. There is no an updated figure, but I am afraid if the another assessment is done, maybe the accessibility will be lower than what we have now officially. That is done at 44% of the total population accessing those services. Now, what are the services that we talked about under the key pillar of health service delivery? Those can be categorized as primary care services, and that is actually the focus or the cornerstone of the health service delivery in the Republic of South Sudan is based on primary health care system. Simply because with an effective primary health care system in place, you will be able to deal or to address more than 60% of the health issues in the populations, especially that our population is rural based. So at the primary health care as a model of delivery, we have three elements of three focus. One is the community level of delivery of those services. The community level, we have a program design and we call it Boomer Health Initiative. This is a program designed to be able to deliver essential services at the community level. These services are basically in form of preventive services, raising awareness of our populations on key health issues, providing immunizations, treatment of the common illnesses like malaria, diarrhea, acute respiratory infections at the community level through what we call Boomer Health Initiative. Is a program is working well. It did not cover 100% of our populations at the rural levels, but is working well through support from the international community, where Boomer health workers are trained on basic elements of preventions and treatment, and they provide those services at the community level. Within the health service delivery, you move further and you talk about the facility-based health services. The facility-based would be within the primary healthcare unit, which is the level above the program design at the community level. Above the primary healthcare unit, you go and talk about the primary healthcare center, which does more than what the primary healthcare unit do as a model of service delivery at the facility level. So in the Republic of South Sudan, we have number of primary healthcare units and primary healthcare center across the boomers and payams of the country. Again, mostly are funded by the international organizations, including, by the way, provisions of essential medications and essential medical supplies, and in paying incentives for those health workers. We all know that the government funding, even the salaries are not regular. People can go for months without salaries, but through support from those international community, mainly donors. And we have two major donors in the Republic of South Sudan, some through the World Bank and some come from a pool of donors known as Health Pool Fund. These are the major donors that include UK, US, Canada, and EU coming together under an arrangement known as Health Pool Fund, and they support the sector beside the support that come from the World Bank and through other agencies like WHO and UNICEF and UNDP, UNFPA, and other health partners supporting the sector. Now, under the health service delivery, also we have disease-specific programs that are designed to address specific diseases, mainly malaria, TB, and HIV. This is mainly come under the support from the global fund for the fights against malaria, TB, and HIV. It is also within the service delivery pillar as a key pillar in the health system. We move beyond the primary care, and we talk about the hospital-based services, and mainly in the Republic of South Sudan, you talk about the county hospital. And county hospitals are elsewhere could be called general hospital or primary or level 1 hospital. These are hospitals that are run by the general practitioner. In the UK setting, it's called GP, general practitioners. Somebody who is trained to be able to do basics of everything, and then they refer, of course, the complicated cases. So in the Republic of South Sudan, we have county hospitals which are level 1. I should also mention that there is these are meant to provide level 1 care hospital services provided by the GP. So each county has a county hospital, but to be fair, I should also mention here that there's huge disparity between County A and County B hospital in the country in terms of the infrastructure development and the human resources. Of course, in terms of design, all the counties hospitals are supposed to be the same, to be delivering the same services, to be having the same manpower, the same equipment, and the same range of services. But the reality on the ground is different in a sense that some county hospitals, for reason or another, are better than the others. And this is a gap that we in the Ministry of Health are working hard to bridge or to address, so that the county hospital across the country provide the same services, the same facilities, the same infrastructure, and the same level of human resource available to deliver those services. You move a little bit beyond the county. Am I being heard, Justin? Justin? Am I being heard?
Yeah, it's loud and clear.
All right, great.
So, we can hear you,
yeah,
Gabriel.
so you move. Okay, so you move beyond county and you go to state hospitals. And state hospitals are meant to be level 2 hospitals. These are hospitals that are supposed to be run by general consultant, a general specialist. Again, not all the state hospitals in the Republic of South Sudan have general consultants. Ideally, a state hospital should have a general consultant in 4 major specialties: in internal medicine, obs and gynecology, surgery, and pediatric medicine. They are supposed to have those at least four general consultant in those 4 major specialties. But of course, the reality on the ground is different. So some state hospitals are basically running like county hospitals with the GP, with the general practitioner. So there is a huge gap there that need to be addressed, so that the state hospital run as level 2 hospital with general consultant providing more specialized services than what people can get from the county hospital. So the chain of referral should be from the primary health care center to the county hospital, from the county hospital to the state hospital. So when you move from the from the county hospital to the state hospital, you are supposed to get more specialized services at the state hospital more than what you get out of the county hospital. But the reality is that some of the state hospital in the Republic of South Sudan are actually run like county hospital, basically with GP, which make them not necessarily like level 2 hospital with general consultant. You move above above the state hospital, and you come to teaching hospital. And we have few of them in the Republic of South Sudan. You are talking about Juba Teaching Hospital, Malakal Teaching Hospital, Wow Teaching Hospital, Kirmayadi in Rumbek, Kirmayadi Women Hospital in Rumbek, and El Sabah teaching hospitals in pediatric teaching hospital in Juba. So these teaching hospitals are meant to be level 3 hospitals. Level 3 hospitals are hospitals that are actually manned by, you do not only have general consultant, but you have super specialists, people who have sub specializations in their area of specialty. So if you have a general surgeon, we are expected also to have a urologist. You have to have cardiologists and plastic surgeons and the rest, just to give an example. Again, we have a huge gap in terms of the availability of these specialized human resources that will make these facilities a tertiary facilities in the sense of the word, because tertiary facilities are supposed to give more specialized services compared to the level 2, which is a state hospital run by the general consultant. So there is also a huge gap there. So again, under the service delivery, which is a pillar number 1, I'm going to talk about 6 pillars. I'm just on pillar number 1 now. Under the service delivery, of course, we have private health sector. Private health sector is important. We in the Ministry of Health, in principle, we approve, we accept that there should be a private health sector. But of course, the private health sector should be regulated and should be professionally run, so that you prevent what we call quacks doctors or quack health personnel from intruding into the sector. So the people in the private sector are supposed to be regulated, to be licensed, and to be for the sector, to make sure that these are competent people providing the needed services, so that those who are able to afford to pay from their pocket for the health services can go and seek those services there. Is part of making service available to our people. And now I am glad until recently we have been having issues of the regulatory body, but now the South Sudan General Medical Council is actually seriously coming up, and they have started now to play the oversight role of ensuring that the people involved in the provision of health services in the country are regulated, including those in the private sector, so that you keep only the the competent and qualified people to provide the needed services to our people. So that is in brief the pillar number one, which is basically the service delivery. So you have the primary care, you have the secondary care, you have the tertiary care, and you have the private sector. For the government, for the primary care and even hospital and even county and state hospital, funding is mainly from our donor. I will talk about that because I will touch on the key pillar of the health financing. Now, number two pillar, you can call it pillar number two or building block two, is medicine and technology. And under this, we are talking about your supply chain system for pharmaceutical and medical supplies, for diagnostic tools. The medicine has becoming, technology dependent, so you need to ensure that you have the right equipments into the country, the diagnostic tools, the laboratory equipments to support you in diagnosis, and of course an adequate supply of chain of your drugs, essential drugs and medical supplies into the country. Under this pillar, we have the Director of Pharmaceutical and Medical Supplies in the Ministry of Health overseeing this. As a government and as a country, starting from 2012 up to now, unfortunately, we have been relying on donors to support the provisions of pharmaceutical and medical supplies into the country, where as a country, because of the financial crisis, we have not been able to do an independent procurement by the government. But I hope things will change and the government budget allocation toward the sector will increase so that we develop our own effective supply chain system that we are able to procure medication and distribute and diagnostic tools to our health facilities across the country. So the oversight role is there. The only major bottleneck under this pillar is the availability of the government funding to ensure that the government does the procurement and supplies of the essential medications and diagnostic tools to our facilities. Moving on to pillar or block number three, building block number three, is human resource for health. And this is very key. The recommendation of WHO is that for every 10,000 population, you are supposed to have 44.5 skilled health workforce, mixed skilled workforce of doctor, nurses, midwife, and clinical officers, and the rest to serve that number of your population. So 44.5, there is no 0.5 human being, actually, you can roughly say 45. So 45 skilled workforce for every 10,000 population. That is the minimum requirement recommended number by WHO for us to achieve the universal health coverage. Universal health coverage is a very simple concept. The concept is that under the universal health coverage, people are meant to access an essential health services that they need wherever they need that and whenever they need that at an affordable cost. They should not go bankrupt to get those services. That is the concept of universal health coverage. So for us as a country to achieve universal health coverage, or for any country for that matter, WHO recommends that you should have at least 44.5 skilled workforce per 10,000 population. Now, as Republic of South Sudan, we stand at 7.6 per 10,000 population. We stand at 7.6 per 10,000 population to compare to the recommended minimum by WHO, which is 44.5 per 10,000 population. Now, with an assumption that we are 12 million, 12 million, and anybody can do that simple calculation, that we are 12 million population, the Republic of South Sudan, we need to train 44,280 skilled workforce to attain the minimum recommended by WHO, which is 44.5 per 10,000 population. We need, again, let me repeat again, we need to train 44,280 skilled workforce to attain that minimum requirement by WHO, so that we have a figure of 44.5 per 10,000 population skilled workforce per 10,000 of our population to deliver, to achieve the minimum, the universal health coverage. Currently, in the country, we train 1,150 skilled workforce through 32 health science training institute that train the mid-level cadre, nurses, midwife, clinical officer, and the rest. 3 medical school, which is Juba, Wow, and Malakal, and some postgraduate training, which we managed to secure through the Ministry of Health in Ethiopia mainly. Some are in Egypt and some are in East African countries. So those that we train as a country in the 32 Health Science Training Institute, put together with the doctors that graduated from the 3 medical school, put together with people who specialize in neighboring countries, mainly Ethiopia, Egypt, and East Africa. If you put this together, you will realize that we are only able to train 1,550 skilled workforce yearly. Okay, now, and if we need to train 44,280 skilled workforce to attain minimum recommended by WHO, then by simple calculation, if you divide that figure, divide 44,280 by 10, you will realize that we need to train 4,428 skilled workforce per year for us to achieve the minimum recommended by WHO in the next 10 years. So we need to double the current, or more than double actually, the current figure we train for us to achieve the minimum recommended by WHO in the next 10 years. So if we continue at the current rate, if we don't increase the capacity, don't increase the number of the people that we train yearly, it will take us 20 years. With this rate, it will take us 20 years. It will take South Sudan 20 years to reach the minimum recommended by WHO. You can do that calculation for yourself. It's very simple. So in terms of human resource for health, which is actually the key pillar, we need to do a lot in terms of training and improving the capacity and the quality of training to reach the minimum requirement by WHO, and at least 10 years from now, if we double our effort. And that entails developing, expanding the current infrastructure for our health science training institute, probably improving the infrastructure also for medical school to train a bigger number than what they train now, and increase the quality and the capacity of training so that we attain those figures. So there's a lot of work need to be done under the pillar of human resource for health for the Republic of South Sudan. For now, our main support comes from UNFPA for supporting the Health Science Training Institute. To the 32 Health Science Training Institute, by the way, some of them are private health science training institutes, so they are run privately, but of course under our supervision in terms of the curricula and the guideline that they use to train. Some of them are publicly owned by the government, and those are supported by UNFPA, United Nations Fund for Population Activities, and other bodies like WHO. Our friend, the Ethiopian gave us an opportunity, a really golden opportunity for us and every year they admit 30 doctors for postgraduate specialization in different medical schools in Ethiopia. Free of charge, we don't pay tuition for that. We only struggle to get upkeep for those doctors. Few of them are in Egypt, and few of them are also in East African countries, mainly Uganda, Kenya, and Tanzania. So we need to do a lot. We need to double our efforts to be able to attain the minimum requirement of human resource for health for the populations, for us to achieve the universal health coverage. Moving on to pillar number 4, and that is health financing. As a country, we have been struggling with the 2% or less than 2% from the GDP, from the total budget of the country allocated towards health. But even that 2%, disbursement is a different story altogether. It sometimes, most of the time, end up in paper. While the minimum recommended by Abuja Declaration is 15%. You are supposed to allocate 15% of your total budget of your GDP to the health sector. Some few African countries have attained that, and actually some other countries have actually surpassed what is recommended by what was recommended in Abuja, that Abuja Declaration, the famous Abuja Declaration of 15%. We as a country are struggling at 2%, and 2% most of the time is a theoretical allocation, because disbursement is different, is a different story altogether. So in terms of health financing, the funding comes mostly from donors through health partners. Even donors funding don't come direct to the government, by the way, because they are reluctant of how we have been managing our own finances. And I have been on record talking to my colleague in the Ministry of Health that I totally agree with them. I totally agree with how they channel their funding. Is an awkward arrangement, but this is how it works in other countries, like in Ethiopia, in Sudan, and even next door here in Uganda and in Kenya. The donor funding will go directly to the government coffers, and then of course the government will make accountability. But for our case, the donor funding come here, goes to the implementing partner. The implementing partner implement the donor funding directly, and that actually reduce the cost that is going toward the actual services, because those implementing partners, we call them implementing partners, they have their administration costs, and that reduce actually the funding. So the donor funding may seem huge in figure, but when it comes to reality on the ground, it is much less than that, because of the admin cost of how the donor funding run in the Republic of South Sudan, which I don't blame them for it for now, until we fix and put our house in order. So in brief, the health financing is struggling with minimum allocation. Even that minimum allocation is not being 100% dispersed for the sector to carry on the activities and all of the above that I have just mentioned in terms of deliveries, training, and the rest of it. Now, moving on to pillar number 5, and that is basically monitoring and evaluation. Of course, you have to have the system in place to be able to monitor what you are doing, to be able to collect the data, analyze the data, and use the data for evidence-based decision making. We have a tool in place which is being used in other countries. It's called DHIS2. DHIS2 is a monitoring and evaluation tool that is a computer-based tool that we use to collect the data across the country, analyze the data, and use the data for evidence-based decision making. Is again working, but with support from the donor funding. Is under my colleague Dr. Kirienda in the Directorate on Policy and Planning in the Ministry of Health, and of course they also structures, other similar structures at the state level. Moving on to, so that I don't take too much time talking, moving on to the last pillar or building block, which is basically leadership and governance. Is a key pillar in the health system, and leadership and governance. The focus of the leadership and governance in the health sector is to focus on the developing the policies, the strategies, playing the oversight role. So at the national level in the Republic of South Sudan, you have the National Ministry of Health, which is the overall playing an overall oversight role in the sector, developing the policies, the strategies, the guidelines that will be used to guide whatever happens in the sector at the national level. You have also at the state level, the State Ministry of Health level, to ensure playing also a leadership and governance role to ensure that those policies and strategies are translated and implemented as it is at that level, at the state level, moving down to the county level. County level is supposed also to have an oversight roles in ensuring that these strategies and the health plans and strategies are implemented. The service delivery is implemented as it is, as prescribed at the national level by the policymakers, counties. So you have the National Ministry of Health, the State Ministry of Health, and the County Health Department. Under the leadership and governance, you also have regulatory bodies, and mainly here we talk about the South Sudan General Medical Council, which is supposed to be a regulatory body, is picking up now. I'm really glad that they are picking up, because without them we can actually end up having real quacks in the sector, and they can endanger the life of our people. And you have also DFCA, Drugs and Food Control Authority, playing the regulatory role in terms of drugs and these toxins and medicines and that are coming into the country. So that is it in terms of the 6 key pillars of the health sector. I touch on the health service delivery. I talk about the medicine and technology. I talk about the human resource. I talk about the health financing, monitoring and evaluation, and leadership and governance. Those are any health system is based on those key 6 building block or pillars. Now, to conclude, what are the key challenges of, and I've been mentioning this all along during my talk, challenges of the sector in the Republic of South Sudan. One is a lack of adequate funding. I can say actually 90% or more than 90% of what happened in the sector happened through external donations. And now with the reduction in the donor funding because of the global crisis, is a challenge for us as a government to increase the funding allocation to the sector, to be able to do all of the above that I've just talked about, to be able to train the enough skill. Lack of enough skilled workforce is also a challenge for us. As I mentioned earlier, for us to now, if we double the current capacity of training, we will be able to achieve the minimum for achieving universal health coverage in the next 10 years. If we don't, we need 20 years to achieve the universal health coverage from now. Poor infrastructure is a key challenge also, of course. Most of our facilities actually, some of them, frankly speaking, will not qualify to be a health facility in the first place. So there's a huge challenge there in terms of fixing those facilities to become the health facility. So the way forward, of course, is for us to increase the funding toward the health sector, to train enough skilled workforce, and to develop adequate infrastructure for effective health service delivery. That is it from my side. Justin and the team, back to you.
Oh, Dictor, thank you so much for that highly intense and encompassing, as well as a stupendous presentation. I mean, I'm so elated. I wish more people were here, but the few that are here, I'm sure will share my sentiment that you've literally covered. You've given us the crux of what is holding back, or the challenges that continue to face our health sector. So we salute you for this, and definitely when we share this on a bigger forum, I'm sure many people will express similar sentiments. So we just want to applaud you for this. Well done, well done. Everybody, the room is open for questions. On my part, I'm very impressed with how Dr. Gabriel presented this. He depicted the picture as it is, the numerous challenges that continue to compound the health sector. The professionalism that is there, if many of the doctors are and managers are highly trained, highly committed, but they haven't been given the tools. These are like people being put in an operational theater with no tools. Literally, that's what it means. Clearly, campaign is needed. People have to bring their minds together, how we can strengthen the health sector and what can be done to cajole our leaders to at least give health a priority. And yesterday we had a discussion on economics and the state of the economy, and we were told in the last year's budget there was only 2% allocated to health. So clearly these are the challenges. So without further ado, the floor is open, but thank you very much, Gabriel. I'll also have some questions later, but I'll allow the others to get in first. Yeah, go ahead. Anybody who wants to dive in can open your mic. Yeah, go ahead, Philip. You're very welcome.
Okay, firstly, I would like to thank Dr. Gabriel for the brief snapshot. I'm Philip Oboy. I'm actually a student. I'm doing my master's of public health at the University of Manchester, and I just have one question. As per your presentation, I've seen the major challenge is the issue of financing. Like 2% used to be allocated, and at times you don't even get the 2%. And actually, some years back, I was working for World Health Organization at the county level in South Sudan, and my role was I was like a technical officer in the field. And during that time, I've observed on how the donors have been cutting their support to the health system in South Sudan. Like at first, it happened in 2019. Like in Ikotos County, there were some health facilities which were knocked out because due to funding. And also it happened in 2023, about 50% of the health facilities were also cut out due to funding. And I'm very sure, like my worry is what will happen if the donors like decided to cut their funding, like maybe to less than 10%. And from my observation, almost all the health facilities which the funding has been cut are actually in terrible situation, because even simple security guards cannot even maintain the health facility. Like the health facilities are becoming like just a ghost house because no one is taking care of, even the community itself cannot even take care of the health facility. And the basic things, even if there's some healthcare workers which are under the support of the government, but they can't also provide the services because there are no medicines or there are no drugs which are supplied by the government. So my worry is what will happen if we keep seeing these things cascading down over and over. Thank you.
Would you allow me to answer directly, Justin?
Yeah, go ahead. The floor is yours, Gabriel. But thank you, Philip. Thank you.
Philip, I think I remember you remotely, Philip. Maybe we have met somewhere in South Sudan here. Well, your question is a great question, and of course, if the donor, and definitely the donor funding is reducing, if the government is not chipping in to increase the funding allocation and disbursement for that matter from the government, then of course you will have all those data will get worsened. The maternal mortality will increase, the under 5 mortality will increase, the malnutrition will increase, will raise, and people will die from preventable diseases, children, mothers, elderly, non-communicable diseases. People will simply die. Is as simple as such. So, and the truth of the matter is that the government, the donor funding is decreasing, whether for their own problems back home where they come from, or whether for the fact that they just fed up, they just fatigued. I was telling my colleague the other day in the Ministry of Health, and I'm vocal about this and open about this. I was telling them, do you guys think that the international financial institution, the World Bank and the IMF, do not know how much currency come to South Sudan, how much hard currency come to South? They definitely know, and they definitely know that this money is not being spent on real project for the people of South Sudan. Is not being spent on service delivery, whether health, education, food security is not. So where is it going to? It's definitely going to individual pockets. And so, frankly speaking, let me be very honest, Philip. I think even the donors are too sympathetic with us. Too sympathetic with us. Otherwise, they would have departed long time ago. But I think they're too sympathetic, and I beg them to be too sympathetic, because the common innocent person in your village, in my village, in Year's village, in everybody's around this stable village is just innocent. It's just innocent, and we need to support them one way or the other. So unless the government increase the funding, and if the donor move out, of course it's going to be disastrous, and you're a public health student, you know those data will definitely get worsened. The maternal mortality will increase, the underchild mortality will increase, the death rate, mortality, morbidity due to common preventable diseases will definitely worsen, and it will be disastrous. I hope we will not get there, and I hope also that the government and the decision makers in the government will listen to the fact that there is a need to increase the funding allocation, not only increase theoretically, increase practically, and also disperse that money for the intended purpose. Yeah. Back to you, Justin.
Excellent, absolutely. Now, the question really that ought to be asked, if this is what's likely to be happening, that there's donor fatigue and a sense of feeling that there's a lot of money in the country. What is being done to lobby, let's say, the parliament or parliamentarians to lobby the government, or even the government to lobby the NGOs or international partners not to give up on us, or to increase our budget, as in the case of the executive themselves? Is there anything that is being done? What is the role of the doctors' union as well, in terms of maybe sourcing private funding or any other ways? Yeah, go ahead.
At our level, Justin, we are talking. We've talked to the relevant people. The doctors' union. They have talked. We've talked to the relevant people. We have the specialized committee of health and social of health in the assembly. They talk actually before not this budget, the budget before that, this one, there was an agreement that the funding allocation toward the health was going to be increased to 10%, and the specialized committee in the assembly they were actually very vocal about that. There are specialized doctors actually among the member of the committee, specialized doctors, 4 or 5 of them in that committee. So the talk and the agreement was it is going to be increased to 10%, but all of a sudden is changed. So you don't know actually who actually make some of these vital decisions behind the curtain. Whether, because if the assembly as accepted and pass something as a policy, to me that should be binding. In a normal setup like UK, if the parliament approve anything, Justin, I don't think 10 Downing Street will shut it down. I don't think. But here things just happen. The assembly approve, accept, but it's not being implemented, and somebody just change it, and tomorrow you have something completely different. So and unless the center of the decision making is serious about some of these issues, we will continue to struggle. And the donor fatigue is real. Now, and I hope this will not happen. Actually, most of our health facilities, the worker in the health facilities get incentive from the donor funding. And that is what keeping them actually in those facilities. Now I'm hearing, talking to some of my colleagues in the international community that are too close to me, whether they are American or they are British, they are actually already discussing about the fact that they are going to stop giving the government or employee incentives. That should be the responsibility of the government, and that is, I hope it will not happen. That if that is going to be happen, it's going to be disastrous, because these workers will definitely desert those health facilities and go elsewhere and look for the means of livelihood for themselves and for their family. So unless the leadership listen to us and we are talking to the relevant people, whether in the ministry, whether in the cabinet, whether in the assembly, unless they listen to this call, we are in for a tough time. Back to you.
Yeah, it's one of those issues. I guess okay. What about the private route? Maybe if we could privatize aspects of the health sector, because clearly, from what we hear and what seems to be the constant, is that the government actually allocates a lot of budget to people who are extremely sick or people who are well known or members of the government. They're given constant funds. At times, these are done very late on, to a point where maybe it's too late in getting any treatment. So surely, should there not be a way of prioritizing investment in effective hospitals, particularly even the primary health, as well as general hospitals that could literally be diagnostic hospitals that could be covering the main ailments. The main ailments, as we know, are there in our country, and yet people have to go abroad. Constant trips to India, constant trips to all over the world, Europe, Germany in particular. So is there any way, maybe if the government cannot find the funding or does not prioritize health, that maybe a tween system of a privatized sector that is organized, or maybe through a PPP arrangement with the government, not just the individuals who create private hospitals, could actually be a way of at least giving some attention to the sector?
We are open to the private sector investment in the sector, Justin and the colleague. We are open to that, and of course, private sector can play a major role. The services, the essential services, or even the specialized services for people who can afford. You factor in the element of you being able to serve people who are not able to go full private. But now some of the investors will be even reluctant to come in for the element of PPP, because most of the time the government will be seen as if not adhering to the part of the bargain. You know, in the PPP, public-private partnership, you are a private entity will be required to do A, B, C, D. The government will be required to do E, F, G, H, and things like that. And so, unless the private sector is reassured that the government partner will adhere to its parts of the bargain, even the PPP may not work. But the private sector is highly welcome. It's highly welcome. It's already happening. Justin and the team in Juba here, the number of private health facilities that are providing services. Some of them are running well, but they can only be accessible by those people who can afford. Of course, there is no way that you are going to enforce your thinking on the private investors in terms of what should be the price and what should not be priced, especially that we are talking as a country. We are talking about the liberal market, liberal economy. So there's a room for private sector, and if there are people who are willing, through you guys in UK, you guys in the diaspora, please come with them. Let us explore that component. At least we reduce the burden of people having to go to seek for those services abroad, which is more expensive than getting them here. And it will actually also make the circulation of the hard currency within the country. So back to you.
Yeah. It involves an element, as you rightly said. PPPs involve a recognition by government that they've got to kickstart the whole process, which means the initial investment and ability to engage would be constant. And now I think of Kenya and how the Kenyan health sector was obviously supported very much by their government, but then with it comes money through insurance, national health insurance. And that whole system can work in our country, but it needs a commitment from the government. And that's the model I'm thinking, where we have subsidized health, where citizens and particularly the employed elements pay their insurance. Employees of government also get aided by the government. So in that sense, it's got to be kickstarted or initiated or really backed by the government. It can't just be lumbered on outsiders. And again, when we see purely private sector as an alternative, as we've seen in North Sudan, and as we see now in South Sudan, that is not the way. It's about who can afford. If you can't afford, you go to the national hospital and you become a victim. So my thinking really is that there's got to be a commitment from the government, and I'm sure we could get insurance companies to come in and have a similar model akin to the Kenyan model, but it needs government involvement.
Yeah, sure, Justin. Yeah, we are open to that. It is an area that we have not yet explored, but definitely yes, insurance, yes, we can, with a reputable company, we can explore that.
Thank you. We want to welcome Dr. Diana Ngargweli. I apologize, Diana, the other Diana, I'm mistaken you for Ngargweli von DJ. She's here with us now, and welcome, Diana, the other Diana. Welcome, Joe. Welcome, James Mo. And Nyon obviously has been with us here from the beginning with Philip. The floor is open. Continue to engage and ask questions or suggest ideas. Share your experiences of our health service back home, as well as health service in other parts of the world that we would want to emulate, or at least try to see if it can be copied in any way, or being considered as a way for future health sector in South Sudan. Thank you.
Thank you, Nyer. Thank you for the welcome. Yeah, hi, everybody. Here is Nyer Joseph Masibier, also known as Diana Joseph. Yeah, I'm sorry I wasn't able to join you earlier because I'm at work. So I have just joined the Zoom meeting. It's very interesting, and I'm really enjoying this. It's very interesting. I would like to thank Brother Gabriel Loi. He's been very supportive of my group. So I have, for those of you who don't know, I have a very small charity called Health Initiative South Sudan. And I founded that charity a couple of years ago, and I've been going to South Sudan on a regular basis, trying to provide health services, which are much needed indeed. So every single thing you guys have said today is just, it's very true and very accurate. And whenever I have a trip, I've always been in touch with Brother Gabriel, and he's been very, very supportive. So many things would have been much more difficult and complicated if he did not support us. So keep doing what you're doing. And yeah, it can be very frustrating the way things are back at home, and the limitations that we have and the limitations that face us. They are very valid and very big. And it's hard to say what the solution is and how these things are going to be solved. And I think it's going to take a long time. It's not something that is going to happen overnight. We just have to be patient, and we have to all do our best and try our part. Yeah, thank you.
Yeah, thank you, Anger. You have been actually providing some services, essential services for people of WOW, and I have been actually getting a good report about your team with your work. So we look forward to working with you and providing those services to our people, and maybe expand on training, and maybe we need to design some training for the midwives, for the nurses, and on-job training for our medical officers to be able to do those essential interventions that you guys have been doing in WOW. So thank you very much for your support.
No, absolutely. And what Anger is doing, thank you, Anger, and welcome. What Anger is doing is the future, really, where if you've had training somewhere else, you also have an opportunity to contribute to the health sector, you would do it. And she's really been doing tremendous work in Northern Bahr Ghazal, in WOW, Western Bahr Ghazal. And I'm sure with more support and resources, she would probably do more. And thank you, Gabriel, for supporting her. It's recently we've been involved with academics in Australia, and a lot of them are people in minerals and in mining, various aspects of science and education in general. And I'm thinking maybe if we could also work. I don't know if you know Peter Loi, who's in Australia. He runs the African World Books. So Peter is somebody I would like you and I and maybe several of us here to talk to, because we could also see to what extent we could get help even here in the UK, maybe. And I know you're very familiar with Dr. Sebed Abbey. He has tried to do a lot, and I think sometimes people get frustrated and projects get hijacked, and there's a lot of issues. But I think there's a constant need for doctors, South Sudanese doctors and their friends on the global scale or in the diaspora, to continuously engage with yourselves with the view of at least, having a regular stream of support, but maybe also to be a pressure group that will force our government to give more money to the sector, force our government to think outside the box and really prioritize health. So I don't know to what extent of late are there such efforts to try and bring people together. If not, we're more than willing to talk to Peter Loi and his group and try to prioritize health and maybe have a couple of conferences where we think beyond the here and now.
Yeah, that's right, Justin. We have been trying to establish those linkages, especially with the UK, those of Dr. Hakim, and the rest. I know the effort of Lual, but I have not been in touch with him directly. But of course, yeah, there are a lot that the diaspora can do, especially in the area of training. I've just shared with you the figure that we have to double our current training. It will take us 10 years from now for us to achieve the minimum requirement for us to achieve the universal health coverage, which is 44.5 skilled workforce per 10,000 populations. We are now at 7.6. And we train only roughly 1,500 skilled health workforce. While if for us to achieve that in the next 10 years, we need to train more than 4,000. We need to be exact. We need to train 4,428 a year for us to do. So I think my interest with the diaspora will be us, and somebody like Anger will be actually to help us strengthen the mid-level cadre training, the training of nurses and midwives. You have seen, and Anger yourself in WOW, I'm sure you have been struggling being an obstetrician and gynecologist yourself, with the basic staff who can support you in the theater, whether nurses and the midwives, and so scaling up those trainings can actually be strengthened through partnership with the diaspora. You guys can mobilize books. You can even mobilize volunteers. People can come here on a voluntary basis for 4 months, 3 months. People who are even retired and they're qualified and they're competent, they can train. We can work with them. if I am the overall in the sector here, it should not be difficult for the government to provide even air ticket for such people and accommodation within the country for the period they are supporting the training, so that we increase and strengthen the capacity of our local. Because without human resource for health, whatever else there is no way we are going to get the other pillars correct without getting the human resource for health correct. We fail in the human resource for health, and then definitely we fail with distinction in the other pillars as well. And so there are a lot that we can do, Anger and the people in the diaspora, to actually strengthen the capacity of our health science training institute to train, especially the mid-level cadres. For now, the universities will struggle with the training of the doctors, will struggle with our neighboring countries until we establish our own residency program for training specialists. That will take time. But my focus now will be to really strengthen the training of the mid-level cadre, who are actually essential in achieving the universal health coverage. Back to you, Justin.
Absolutely. And I think we're commending her for all that she's done so far. I wanted to put it from another angle, Gabriel, because we have a host of embassies around the world. We salute and applaud and appreciate all that Ethiopia is doing. But why is Kenya not doing the same? Uganda, Tanzania, South Africa, Europe, and what is being done by the Foreign Office to try and, or the Ministry of Foreign Affairs, to try to address some of these issues? And is there anything that the health ministry does to pressure and also coordinate with the Ministry of Foreign Affairs in this light? I know there's many countries are supporting us as development partners, but this extra training could easily be done through other ways, and even if every country gives us 10 slots to train the middle cadre, that could possibly help if it's going to be costly. Go ahead.
They can give us Justin, but I don't think they will give us for free. Maybe for historical reasons or for whatever reason, Ethiopian we have been generous to give us 30 slots every year free without tuition fee. But I think we can get those such a slot in Kenya, in Tanzania, and Uganda, but not for free. It has to be investment, because even for them, for their own children, they are not doing it for free. So why do you think they should do it for free for South Sudan? I think it's just a question of us understanding the fact that human resource for health is key, and we need to invest. So we need to pay money, and it's not a lot of money. To be very honest with you, Justin, for a country like South Sudan that produces oil, that's people are dishing dollars left, right, and center for nothing in return. Okay, so I think the pressure that we can talk about is the pressure on the government to increase the investment on the sector, so that we are able to get those slots and pay for it. I personally, I don't believe in free stuff, Justin. And then for how long shall we continue as a country to beg when we have resources? We have resources. We can pay. I don't think it's difficult for a country like South Sudan to pay 4,000 or 3,000 or 5,000 per doctor per year, to pay, let's say, 15 or 20 per doctor for the specializations, 3 years or 4 years. It's not a lot of money for the country like South Sudan. It's just the absence of the will. So if there is a pressure that we need to put, is the pressure for the leadership to understand that it is important to do this, and that is the only way for us to reduce all these people dying unnecessarily or going abroad for struggling to get the essential services abroad. So those countries will open their door for us, but not for free, I'm afraid. Back to you.
I just want to dive right in there and comment to something you said, Brother Gabriel. Yes, training, and especially training of midwives and scrub nurses and nurses in general, is a very essential step. And yes, it's been quite challenging. Like when you work there, there has to be a lot of training to be done, and we are very my charity is very very keen in doing some like training work and stuff, but our biggest disability and biggest limitation is time, really, because obviously we all have obligations here in the West, and when we go down to South Sudan, it's usually for a very short period of time. So in the end of the day, it feels like just a drop in the ocean. But we have a lot of interest in training. So what I would suggest, I would definitely try next time I come to South Sudan, maybe we should meet again and sit down and have a proper conversation of how we can go about with training, especially the midwife. We tried doing that in WOW before to train the midwives, but the situation was just, the whole thing was very challenging. It was difficult, but I think if it's planned properly, it could definitely bear fruits in the future. So that is a conversation to be had, definitely.
Yeah, sure, definitely, yeah.
Absolutely.
We look forward to having that conversation.
Thank you,
Thank
Ngar.
you. Thank you. I'll be in touch as soon as I know when I'm coming.
Gabriel, you're in the right place because your heart is in the right place. You're very professional. The training aspect is actually the linchpin of the whole thing, because if we have the capacity and our people have been working for free anyway, we could possibly, even if they don't get salaries, at least our people would be taken care of. So the question really is, clearly also there's a lack of recruitment, and so we want to know what's the state of the health sector in terms of the cadre you have. Are you able to retain them, or are they being pulled by the private sector, or are they even changing professions? What's the general state at the moment?
At the moment, there is no active recruitment because of this salary thing and no money and stuff. Majority of our colleagues actually are in the NGO, the well of NGO, and unfortunately, some of them are actually involved in doing things that are way beyond their qualifications. So you are a surgeon and you are working with NGOs doing something which is not necessarily your skills, just because the government is not able to pay you well. Or you are a medical officer and you go and accept a position for a nurse or a clinical officer in an NGO, and you do way below what the medical officer is supposed to be doing, just simply because the government is not. So people are not necessarily in the public sector. They are in the private sector, and they are in the NGOs, and in the NGOs they are being underutilized because of the position given to them, and that is the available position. An NGO will tell you, I have a position for clinical officer, you are a medical officer, you accept it or you don't accept it, it's up to you. So and you are getting 2,000, 3,000 US dollar for that position, and you compare to what you can get in the government, so you pack and you go. So until the government remunerations is actually improved, so that people are paid well, brain drain, whether to the private sector or whether to the NGOs or whether to the sector that are completely irrelevant, will continue to be the order of the day. Because you see, even now in the oil sector, you see some colleague going to the oil sector, and when you see what they are doing, it's not necessarily health as such. It's not necessarily, addressing the key element of the health sector that I talked about earlier, the key building block, the sixth building block. Is addressing none of those. But because they have no option, they have to be there. So the key challenge is for the government to improve the package for the recruitment and retention for the health workers. Some work has been tried. There was, people were willing to think that thing will change, but now it seems that is dying. So it's a key challenge. and until the government fix the and improve the recruitment and the retention policy, that will continue to be the order of the day. Back to you, Justin.
Well, thank you, Doctor. Yeah. Anybody else? Any questions for Dr. Gabriel? Thank you, Nyon. Please feel free to open your mic. Perhaps I can ask Gabriel. In terms of training and for nurses, midwives,
One is trying to talk, but I think his mic is maybe mute or low. He's trying to talk actually.
Okay, Nyon, go ahead. Nyon, go ahead. Nyon, your mic is closed. It's muted. Try again. I think they've been having issues ever since. Nyon, try again. Yeah. Okay, Gabriel, let me just ask another question. The training institutes, the ones that are local, do they have the capacity? Are they delivering training? How much does it cost in general to train a nurse or midwife? And whether people could be trained locally, is that a possibility?
Yeah, I have talked about that. We have 32 health science training institutes that train nurses, midwives, and clinical officers, lab technicians across the country. Out of those 32, some of them are private, some of them are faith-based, are owned by the church, and some of them are owned by the government. Those that are private and faith-based, of course, they don't have funding issues, so they are working well. Some of the government health science training institutes that are funded by the organizations are also working well. They are funded by mainly by UNFPA. There are few of them who are left out, but we are trying now to negotiate to include those things. But of course, the donor funding is going down. So again, is donor dependent. But of course, we need to increase the capacity and improve the quality. And they are using curricula which is basically used in the region, is in the East African region. But of course, there are issues of enough competent tutors. So the ratio of tutor to the student may not necessarily be what is the ideal because of lack of enough tutors. We are trying also to train tutors within the country so that we have competent tutors deployed, and at the meantime we are being helped by the UNFPA to do that. So that is working, but definitely we need to increase the capacity and improve the quality. Yeah, the quality. So there is a room, and this is where I think people like Dr. Anger, and the diaspora can actually chip in and support, especially when I talk about the competent tutors or the competent staff to train people. We can get from the diaspora people who are on retirement. Our role in the government will be to give them accommodations and feeding and maybe a air ticket to and fro. Come here for a few months, go back and train, and that will can actually improve the quality and bridge the gap, the current gap that we have in terms of the competent tutors. Yeah,
absolutely.
So back to you.
So thank you so much. Nyon, in case your mic doesn't work, just text and we could read it out to the group. Anybody else? Feel free. I wanted to recognize the efforts of the new minister. I think she's really an amazing human being who's really trying to do her best. She's even been recognized internationally. Minister Will. So we wanted to, and again, I'm sure she's the kind of person who could probably pressurize the government or the executive to allocate more. Now the question is, and hopefully she'll stay a bit longer. because there's a tendency for people to be moved quite regularly. So I think the question really is capacity is not lacking. Yolanda Wilding, the capacity is not lacking, and I think you've got a good minister there. So we really hope you know the combined efforts of all of you could probably yield some progress in the sector. So the next budget, is there a possibility of maybe getting that increased?
we if it is left for us, Justin, we will definitely have the whole money of the government of South Sudan toward the health sector. But of course, some of these decisions are beyond everybody, including Honorable Minister, I'm afraid, because if the specialized committee in the assembly would put a pressure and will be accepted that okay, your budget will be increased to 10%, and then the following day or the next two days or 2 weeks down the line, somebody else is saying no, and you don't know who is the person, and you end up having the same budget that you have been crying about, having the same figure of 2%, which will not be given to you, then of course the center of the decision making is elsewhere. Frankly speaking, I really don't know who decide the finance of this country. We simply don't know in the Ministry of Health, and I am afraid, including the minister, including whether the current minister or the former minister, they simply don't know who decide, because someone else decide that give them this, give them this, give them that. We don't know who is that person. That's the thing. That's the thing. We simply don't know. We simply don't know. So all of us will work hard, including Yolanda, that let the budget of the health sector be increased, but the decision will be made elsewhere, and consistently for the last few years, it has not been favoring the sector. It has been 2%, less than 2%, and the disbursement is a different story altogether. Yeah, so that is it, Justin.
Thank you very much. I think if there's no more questions, we will probably conclude. If anybody wants to ask anything or contribute a comment. So I think Dr. Gabe,
those people who are not able to write to talk, they probably can write on the chat, and then you reread it, and then before we conclude,
sure,
maybe give them some few other 5-10 minutes. They can write on the chat, and then you can read it aloud, and then share it with everybody, and we share the answer.
Sure. I've just gone on the website of the ministry. It says rights to health, quality health, pro-poor community ownership, and good governance. This is some of its beliefs, values.
Yeah, we have. I don't want to brag about the Ministry of Health, but we have some of the best documents in the government sector, Justin. But they remain document.
A healthy and productive population fully exercising its full potential.
That's the visions of the health sector.
That's the vision. Yes.
Yeah.
Mission to improve the health status of the population and provide quality health care to all people in South Sudan, most especially the vulnerable women and children.
Yeah.
So these are commendable visions.
I can share with you the strategic plan that we have. There is a costed strategic plan.
Please, if you can, share it.
Yes, there is.
So we want to thank you very much, Dr. Gabriel. For sure, this lecture would be shared all over the place, and we would wish and hope. One of the things we want to see, again, the diaspora, as frustrated as people can be, if they join hands in Australia, America, Europe, all over the world, wherever they are, they can do something. Even if it's a small dent in the general attempts to forge ahead and have a better health service. I'm sure it can be done, but it needs people to think beyond the here and now. Yeah. As there's any last words on on what you think is achievable in the immediate sense of, if one had to say what are what's an immediate rescue package or anything major, the bare minimum that citizens can do externally to support the health sector.
We will continue to push the government here locally inside to increase the funding allocation to the sector. But I think the diaspora can support, first of all, through mobilizing the volunteer who can come here for a bit longer time with a certain arrangements with the government, support in training, support even in service provisions. I know, like Abe used to come, Dr. Hakim used to come with the team, and they stay here for some time, provide some services, and along with that, they provide some in-service training. The diaspora can mobilize even medical equipment, can mobilize textbooks of medicines for nurses, for midwives, and then we see how with the government to chip those into the country and keep those books in our health facilities for reference for people to learn on. So that there are those things that can be done by the diaspora. But of course, the basic should be done by the government, and that will only happen through increasing the budget allocation toward the sector. Yeah, that's what I can say.
I think when it comes to like medical books and stuff like that, we could definitely try to do something on that front. It's going to be hard from Germany because here the books are all in German language. But I have some contacts in the UK and also people from Australia, like Uncle Justin was saying. I'm sure we could. It would be nice to collaborate. This is something that could easily be done. And on the other hand, when it comes to volunteers coming down, our biggest challenge over here is getting donations. To get donations to get our trips funded, it's very difficult. So if the government could at least provide flight tickets and accommodation in South Sudan, that would be a big weight lifted off our shoulders. That would definitely be something that is very helpful for us. So maybe if we could talk more on those fronts, it would be very nice. Actually, I'll be coming down to South Sudan next month. So, Brother Gabriel, I'm looking forward to meeting with you. Then maybe we could discuss more about this when I'm over there. Yeah,
absolutely.
That's wonderful. Yeah.
Justin, I can see Mo. I can see James Mo has opened his mic. Maybe you wanted to talk.
Yeah, Mo, go ahead. Yeah, go ahead, James.
Oh yes, hello everyone.
Hi, Mo. Hi, James. Yeah, go ahead.
Yeah, I'm James Deng. As an aspiring doctor, I'm really glad that you people have taken this initiative. Justin, Dr. Gabriel, and all those who have contributed. At least it shows there's hope for our people. I've been to South Sudan, and the health sector is, well, we have a lot to do. And if I have seniors who are really contributing to our country's health sector, it's really encouraging. So I appreciate your enthusiasm, your determination to at least help our country. So I'll just tag along. I'll try to learn along the way. When I have the qualifications to at least aid, I'll do what I can. Thank you.
Thank you so much. Thank you, James. Yeah, and then James has a lot of passion for the profession as well as for the country. So we salute you. He's a student here in the UK. Yeah, lovely. Dr. Gabriel, I think we'll let you go, but I have a burning question I want to ask.
No problem.
You know, the Eritrean people's what was it called? EPDF, I think it was. Even in the liberation era and liberation area, they were producing basic medicines for their people. Now, I'm wondering, are pharmacologists, is there anything being done to produce generic medicines locally?
I have asked also the same questions to the colleague here in the department, and quite competent colleague, by the way, who are running this department. Dr. Moses Moses Dengmolwal, who is the Director General of Pharmaceutical and Medical Supplies in the country, is an experienced pharmacist himself. He specialized actually in quality assurance. His specialty is quality assurance. And he has been working with the big pharmaceutical company globally. I think Pharma, Medica, some big names. He has actually been an employee of those companies for some time before he moved to the Ministry of Health in Juba here, Dr. Moses Dengmolwal. So listening to him and to other colleagues, I think some of the key challenges are outside the mandate of the Minister of Health, and this is one of the things that we have. I don't know whether it is intentionally or I don't know, or we just we simply don't know, or lack of awareness. Is the fact that we fail to provide a reliable source of energy, power, Justin. Had we developed, for example, the Numili hydroelectric power, it would have been easy for companies for basic things like IV fluids, like generic medication that you talk about, basic antibiotic to be produced locally. But now there's no source of power in the country. The electricity that we have in Juba, Justin and the team, I think yourself, you have been here, is the most expensive electricity in the planet Earth. Very expensive, very expensive, very expensive. And so will not encourage the actual investment. Some 2 months ago, I was on Ethiopian Airways going to Ethiopia to Addis, and I said next to an Ethiopian man, and we started to talk, and I got to know that he's a businessman, and he was telling me one of the major weaknesses that people cannot invest in South Sudan is electricity. It's simply very expensive, very expensive. So unless we put those fundamentals in place, it will be difficult for a basic investment to kick off in the Republic of South Sudan. So, but those are actually beyond our mandate as Ministry of Health. Yeah. Back to you.
Yeah, I know energy is lack of power is one of those issues. Yeah, but are there plans by the ministry or even those individuals if power is there?
Individuals are willing, yes. There are people who approach. There are people who approach the ministry who want it, but of course, doing the feasibility study of their own, they cannot start the whole thing because of the lack of ABCs. Electricity, running water, and things like that. Yeah. So.
Yeah. Thank you.
Yeah.
Thank you, Nyon. Thank you for that response. Nyon responded here. Said thank you so much. Thank you so much, Dr. Gabriel, Justin, and others in the team for organizing this important Zoom meeting to discuss South Sudan's health matters. The whole problem resolved around the leadership and ignorance from MPs in the National Legislative Assembly to advocate for health matters in national finance budget in the country. Yeah, which is along the lines of, we don't want to put you in there, but clearly, Nyon, we agree with you that there's a lack of funding for sure, and the lack of funding, whether it's out of ignorance or despair or just a sort of a wall, a blockade or bottlenecks, there's something amiss. But clearly, as part of the peace dividends, health is a key service that must be delivered to the citizens. Yeah. And our people are literally in the rural areas in particular, and even in towns, if you don't have the resource, you can't get treated. And as Gabriel and others have said, there's an element of fatigue among the NGOs, and people feel there's enough money in the country. Yeah. So, but I really think people are not ignorant of this, but maybe we have to get to a certain stage before some kind of reawakening or a sense of recognition we've done wrong by our people. Yeah. But thank you.
Yeah, Justin, if I may come in,
yes, go ahead.
I agree with Yuan, but that lack of funding is definitely the major issue. But I'm not sure I would want to blame the ignorance on the MPs. I know those MPs, the specialized committee in the assembly, has at least 4 or 5 senior medical doctors. Some of them are specialists, actually, specialist medical doctors, and they have been pushing for this. So if there is lack of budget, if it is because of ignorance, then the ignorance will be on the final decision maker, the final person who makes the decision that health should take this or that, or should not take this or that, is the person who should be blamed. If that is done out of ignorance, then it is that very person. If it is intentional, then it is that very person. But I'm afraid I want to defend my colleague and say it is not them in the assembly. No, I know there are competent people there, and they actually the chair of the current health specialized committee. She's not a doctor, but she's a very vocal woman. I listened to her a couple of times, and of course she get the information, so, what to say from her colleague who are specialized, and she is very eloquent in what she said, and very determined that the health issues should be addressed. But of course, I'm afraid the final decision maker is not them. It's as things stand now. I don't think it's an assembly, because how do you explain the fact that assembly has approved it today that 10% will be allocated for health? When come to an implementation, is not 10. They themselves are shocked that the figure is not the same like what they have. They have pushed for, and they have approved. So, if there is ignorance, that ignorance should be blamed on someone else who is not necessarily in that assembly, and who is the final decision maker. Whether he or she make the decision based on because of ignorance or intentional, I simply don't know. But it's someone else. It's not assembly. Back to you. Back to you, Justin.
Oh, thank you so much, Dr. Gabriel. Thank you for that, and thank you, Yuan, for your input. Sorry that your mic gave you some difficulties, but thank you all for joining. I think we need to conclude, but there's just a quote here about the importance of healthcare. It's from a person called Rod Blagojevic. He said, "Healthcare is not a privilege; it's a right. It's a right. It's a right as fundamental as civil rights. It's a right as fundamental as giving every child a chance to get a public education." This is our dream. We hope at some stage we will get the right health service, and the social contract that commits government and state resources to be allocated accordingly for the benefit of our citizens. Hence why we organize this. We think through the People's Charter as an advocacy group, we really want to prioritize and talk to whoever to prioritize health, and as a part of the social contract, health as well as education, as well as peace, and the rights to equality and fairness are all enshrined within those civil rights within a social contract. So we want to thank Dr. Gabriel. If we can give him a last word if he wants to say anything. And we thank all of you for having joined us. Jada, do you want to say anything? I believe this is Nicholas.
No, you can conclude, Justin. You can conclude.
Conclude. Okay. Nicholas, do you want to say anything? He's a member of the People's Charter.
Jada. I have just one thing that sort of probably has sort of we have overlooked, which is whether the health ministers or the health ministry in South Sudan is actually considering the non-pharmaceutical health benefits of any knowledge that we have gathered or inherited from our ancestors. Sometime back, we used to rely very little on pharmaceutical medicine, and as the world moves on, or as I've grown up, I've seen our dependence on pharmaceutical medicine more than the natural ways in which we used to take care of ourselves. So I was just wondering as to whether the Ministry of Health is actually considering or doing anything in that light, because for me, that is much more of a prevention approach to any health issues. I haven't heard anything on that line, but obviously I'm at the end of the discussion, or we're at the end of the discussion. So if Dr. Gabriel has any ideas or any knowledge on how the ministry is sort of trying to revive that approach to managing our health through prevention. I'll definitely appreciate it. Thank you very much, Justin, for the last minute. I was sort of engaged with some other stuff. That's why I sort of joined in very late. But I'm grateful for the opportunity. Thank you. And thank you very much, Dr. Gabriel, for your enlightenment. I hand over to you, Justin.
Thank you, my brother. Thank you for joining, Jeddah. It's wonderful to see you. We all have a lot of family stress and responsibilities, so thank you for your sacrifice and everybody for that matter. Your question is very valid. Over to you, Gabriel. Alternative medicine.
Thank you, Jada. Thank you, Jada. Yeah, you missed part of my earlier talk, Jada. And in earlier talk, I talk about the six building block of the health system. One of them is, or number one of them actually, is health service delivery. And within that health service delivery, there is a primary healthcare focus. There's community element, and there is facility-based intervention. And community-based intervention are basically preventive approach to raise awareness of people to be able to prevent themselves from getting those diseases in the first place. Because actually, most of the diseases that we have here, more than 60% of them are preventable. They can be prevented. You cannot have them in the first place, actually, if you adhere to the basic preventive measures, including vaccines, of course, including immunization. But if you're talking about that is part of your question. But if you're talking broadly about the traditional medicine, of course, there is a room for traditional medicine, but it has to be researched. It has to be approved by the regulatory authorities. Next door here in Kenya, in the middle of town, and near you have been to Nairobi. I have been to Nairobi, and I'm sure people around the table here in the room have been to Nairobi. In the middle of Nairobi, in the street, in the main street, actually, is Kenyatta Avenue. There is a big center for traditional medicine there, but it is approved by the Kenya medical authorities. So if we have to have one in South Sudan and there is room for it, it has to be approved by the South Sudan General Medical Council, and it has to be approved by the Drugs and Food Control Authority. But of course, there are no people who came up professionally with that. But of course, to do it under the table, of course, is risky for people, because it is true that those herbs could be medicinal, but they could also be dangerous to our people's life if they are not professionally used. If they are not professionally used in terms of the side effect of those herbal in people's life, in the people's system, mainly the renal system, the liver, the kidneys, and the rest of it, and even causing ulcers and all those complications. So in short, there is a room for traditional herbal medicine, but it has to be approved by the relevant authorities and regulated. But so far, apart from some few people here and there who go on in the street who are not actually licensed, we don't approve those. But there are no people who came up professionally and wanted to set up a center for herbal medicine. But there is a room even in our health policies mentioned that the traditional herbal medicine is encouraged, but it has to be regulated by the regulatory authority within the health sector. Back to you, Justin.
Thank you so much, Dr. Gabriel, for that response on homeopathic remedies or traditional medicine. And thank you, Jada, for the question. You mentioned regulation, and you did mention earlier that there's a new body that is hopefully going to be regulating more. South Sudan has been said to be a dumping ground for many things, including, false medicines. And there's a lot of this going on even in Kenya. And we all know some of the sources. To what extent has that been regulated, and has it been curtailed a bit? Because are we just getting substandard medication, or is there a way of regulating them and making sure, our people are not being treated with substandard medication?
The Drugs and Food Control Authority is there. The colleagues are there. Obviously they need to increase their capacity, but they are there to regulate the incoming medication, importation of pharmaceuticals and medical suppliers into the country to ensure that we don't get substandard and fake medications. Nowadays, it's very tricky, by the way. It's a very lucrative business, and if people are not careful, you can easily be taken for a ride. So yeah, the regulatory authority, the Drug and Food Control Authority, to regulate the drugs and the food coming into the country, they need to increase their capacity to be able to do more than what they are doing now. They themselves admit that they need to increase their capacity. For the other medical component, the registration and the rest, the South Sudan General Medical Council is there, is currently active, and they are trying now to scale up the regulatory component in terms of looking at the clinics, the private, the hospitals, and the personnel running those facilities to ensure that they meet the basic criteria of what they are doing. So yeah, they are there, the regulators are there, but of course, definitely we need to increase the capacity to be able to do more than currently being done. Back to you, Justin.
Thank you. I think it's been a very enlightening afternoon where Gabriel has really given us the A to Z of the health sector and the various challenges, its potential, its capacity, and what hinders them, and what are the shortages and all of that. So I think it's been a good session, Dr. Gabriel. We'll definitely, as always, you're also a member of the Charter. You're always welcome, and clearly this was a very useful and beneficial lecture. So we thank you for kickstarting our lectures. There was a few lectures planned, but various participants got busy. So we thank you for kickstarting this. There'll be another lecture next week. If you guys have shared your contacts with us, we'll give you maybe 3 minutes. If you often get our publicity stuff, there's no problem. But otherwise, send your emails or phone numbers, and we'll share and update you. There's a lecture on there's a discussion on economics and the continual economic challenges in our country. But we want to even look at the role of technology in economics, in economic empowerment. But we want to look at issues around development, and we'll eventually look at infrastructure and economic benefits of infrastructure. So this is an ongoing series. There'll also be another lecture next week. The committee will decide what is being discussed, who will give a lecture next week. But if you want to tag along, or you want to join us, even join the Charter, we need bright and able South Sudanese like all of you to do your part. Is a civil exercise. We're not against anybody. We want to prioritize the interests of the country. Jada and myself, Gabriel, who have joined us, and that's what we're trying to do. Yeah. So thank you for this afternoon, Gabriel. We salute you. May God bless you and continue to give you strength. May you continue to excel and do your best with your colleagues. And remain positive, which is a characteristic you have, considering all the odds. Yeah, so thank you for that. Yeah, thank you, everybody.
You're welcome. Thank you, Justin. Thank you.
You're welcome.
Thank you, everyone.
Everybody. All the best. Yeah, thank you. Yeah,
Bye-bye.
Yeah, bye-bye.